Hi, so the third part of this three-part series is going to look at the cardiovascular changes with shock. Just a quick reminder that we're looking at a two-pump system. The left side of the heart controls the systemic circulation, and the right side, the pulmonary circulation. And in this lecture, we're going to talk about various types of shock. Again, you can pause the video and just remind yourself of the specific parameters we look at in relation to the left or systemic circulation and the right or pulmonary circulation. So we're going to actually start with cardiogenic shock, really because it leads on from our talk about heart failure in the previous lecture. So cardiogenic shock is really a severe example of cardiac failure with a severe failure of the ventricular pump. So ventricular contractility is significantly reduced, leading to a severe increase in left ventricular ejection fraction and a decrease in stroke volume. On the downside of the system, so the outflow tract, we get a significant decrease in cardiac output, leading to a decrease in mean arterial pressure and a reflex vasoconstriction. This leads to significant reductions in blood flow throughout the body, affecting all organ systems. So the patient is in shock. Remember that shock is defined as inadequate tissue perfusion to maintain the body's normal metabolic demands. The pump failure ultimately leads to a backup of blood in the lungs, pulmonary congestion, which then puts pressure on the right ventricle, which is not really designed for high outflow pressures. And ultimately, this leads to a failure of the right ventricle and backup of blood into the vena cava, increasing the CVP and leading to a plethoric vena cava. And of course, as we were saying, this is on the basis of a decreased right ventricular ejection fraction, an increase in right ventricular end-diastolic volumes and pressures. And as we were mentioning, there's an increase in pulmonary capillary wedge pressure because of a backup of blood from the left heart into the lungs. So that's cardiogenic shock. Before we leave heart failure, most of our discussion was based on heart failure due to reduced ejection fraction. You would have come across a term called heart failure with a normal ejection fraction. And in these patients, there's still a reduction in stroke volume, leading to the inability to deal with venous return. But whereas with heart failure with a reduced ejection fraction, this is because of poor ventricular contractility. In heart failure with a normal ejection fraction, this is mostly due to a lack of compliance in the ventricle. What that means is, as blood is flowing from the left atrium into the left ventricle in diastole, there's a lack of ventricular compliance and the ventricle can't relax to accept the blood flowing into it. There are two situations that aggravate this. The first is a thickened ventricular wall, so it's often seen in older patients with chronic hypertension, and the other is due to a fast heart rate. So in patients, for example, with fast atrial fibrillation, diastolic filling time is reduced, and that leads to a compromise in the ability of the ventricle to accept blood from the left atrium during diastole. What about hypovolemic shock? Well, the main thing in hypovolemic shock is a decrease in intravascular volume. That leads to a decrease in the amount of blood flowing from the left atrium into the left ventricle, and that will lead to a decrease in stroke volume because there's not as much blood. However, the heart itself should be normal, and in a response to this, there's an increase in contractility, an increase in left ventricular ejection fraction. But because there's less blood in the system, there will be a decrease in left ventricular end diastolic volume and pressure. This poor cardiac output then causes a reflex vasoconstriction, but although this might maintain blood pressure initially in the early stages of shock, as shock proceeds, ultimately this reduced intravascular volume and reduced cardiac output leads to a decrease in mean arterial pressure. There is a regional difference in blood flow. The blood flow to non-essential organs is decreased in an attempt to maintain the heart, lung, brain circulation. Of course, if there's a decrease in the intravascular volume, that affects all parts of the system, and therefore the venous return to the right heart would also be decreased, leading to a low CVP and an underfilled IVC, reflected as increased IVC collapsibility during respiration. The blood going into the ventricle is reduced, right ventricle, so there's a decrease in right ventricular ejection fraction and a reduced in right ventricular end diastolic volumes and pressures. And ultimately, less blood is pumped through the pulmonary system, so there's a decrease in pulmonary capillary wedge pressure. Finally, let's look at septic shock. Septic shock is a combination of decreased intravascular volume, peripheral vasodilation, and to an extent decrease in cardiac contractility due to a combination of inflammatory mediators and endotoxins. So the cardiac output is decreased because the decrease in venous return due to the hypovolemia, but also venous pooling because of vasodilation reduces the amount of blood getting back to the heart. As a response, there is a decrease in mean arterial pressure. However, unlike hypovolemic shock, the patients have vasodilation due to their other problems caused by endotoxins and inflammatory mediators, and therefore they have vasodilation and a decrease in systemic vascular resistance. This is exacerbated by a shunting of blood at the capillary tissue level and inappropriate vasodilation, as we discussed. Of course, this then feeds back through to the venous return to the right side of the heart with vasodilation, pooling of blood, hypovolemia, leading to a decrease in venous return, a decrease in CVP, and an increase in IVC collapsibility because of a decrease in volume of blood in the IVC. Since less blood is getting through to the right ventricle, there will be a decrease in right ventricular and diastolic volume and pressure, and initially at least an increase in the contractility of the right ventricle to try to compensate for this. However, as we said before, some of the endotoxins seen in sepsis can lead to a decrease in ventricular contractility and a decrease in the right ventricular and left ventricular ejection fraction. And of course, ultimately, the lack of blood and the poor perfusion feeds through to the pulmonary circulation, leading to a decrease in pulmonary arterial wedge pressure. So again, if you have any questions, you can post them on the chat or bring them up in class. In summary, we looked at the cardiovascular changes in health and disease, picking out some of the key parameters that are used to both measure cardiovascular status and explain these cardiovascular changes in health and disease. Thank you.